So a couple of words about our company. Kasamba is the largest software and services provider in the post-acute therapy space. And with our recent acquisition of TherapySource, Rehab Toolkit, and HealthWise, we're excited to be able to offer expanded solutions that help providers across the entire therapy continuum of care, which includes skilled nursing facilities, contract therapists, home health, and of course the outpatient clinic. And our presenter today is David McMullan. He's the Vice President of Products at Kasamba. He's also a physical therapist with over 20 years of experience in a variety of different healthcare settings, and he was one of the chief architects behind our TherapySource software. You may also recognize some of his work from industry publications, including the upcoming issue of Advanced for Physical Therapy and Rehab Management. He'll have a fun article that kind of goes over the business evolution of PT that I think you guys would enjoy. But I'll turn it over to him so we can talk CPT codes today. So David?
Good morning and good afternoon to everyone representing all the time zones. Happy belated 2017. Excited for what the year has ahead of us in numerous things, and I think I've kind of messed some up. You're never done editing, or you're always tweaking something, so I think I kind of have my slides out of order, so I'm going to go back to the agenda just to cover off a few things. So just so you know what we're going to cover, a real quick review and update on the new eval codes, just sort of a level setting or base setting. Then I want to talk about some updates and changes on the new eval codes, kind of what some of the things we've seen or heard since December and into the first month, et cetera. The other thing I wanted to share with you is we pulled some stats from utilization on the new eval codes, and so to give you a really good sense of what we're all picking in both PT and OT and how that's going. And so when you look at the levels of complexity, what is that looking like, right? Everyone, we all sort of have a thought or opinion on what we're going to pick. And so to give you a little snapshot into that to give you some sort of sense. Some additional tips and tricks to be thinking about as you're going through this process of how do I pick the right level of complexity, when do I pick it for a variety of different things or different settings, what about the payers, et cetera. And then the frequently asked questions really section is a number of questions that we've gotten as an organization that I've seen out there. Some of them may have come into APTA or AOTA and stuff, so I tried to combine a number of, a lot of them are duplicative, so just kind of summed up and took kind of a real good snapshot. I want to walk through those. Those will all be part of an FAQ sort of living document we're going to have on our internal community for our clients to be able to see, and you can query and see those things as they continue to come up. And then an opportunity for questions and answers to submit on the fly, things that you've seen come up, today, yesterday, last week, with respect to either the clinical side or the documentation side or the billing and coding side with respect to, specifically to these new eval codes, et cetera. I want to make you aware of some additional training resources we're putting out with respect to that, and just managing these and working through some of the things we'll talk about. And then obviously all the resources that I pull on, that I know they're available, continue to want to give you those links and access to those, et cetera. The other thing, and Megan may have alluded to, that we will make all of the slides available to everybody. We'll make the presentation available to everybody for those in your organization who didn't have an opportunity to attend live, so we'll definitely do that. And we like to provide this material as much as possible. So with that, I'm going to jump a couple of slides ahead, and let's do a quick review of the new evaluation codes. So it just so happens that today is Groundhog Day. So good old Puxatawny Phil unfortunately appeared. Those on the East Coast probably already aware. So he appeared this morning and got up, and unfortunately he saw his shadow, so he's predicting 6 more weeks of winter. but that's not necessarily why I threw this in here to depress you all about more winter. But one of my favorite movies that Bill Murray was in was Groundhog Day, where he continues to live the same day over and over again. And we'll talk a little bit about that, because some of the same things with the implementation or expectations around payers and other people being ready for these new codes like they were supposed to be, it's kind of like Groundhog Day with functional limitation reporting or some of the other things we live through as we get ready, but they're not. So we'll talk a little bit more about that. So from the new PT eval codes for 2017, obviously these were effective Jan 1. The AMA put them out, and they were part of the physician fee schedule proposed rule and final rule in November. So the old evaluation code 97001 and the re-eval 9702 are deleted and inactive codes, and they're replaced by the 3 new eval codes and the 1 new re-eval code. Different levels of complexity, et cetera. And these pertain to, if you are a HIPAA-covered entity, so any of the payers that are HIPAA-covered entities are supposed to comply and adopt all of these new codes January 1st and not continue to accept old legacy codes. And so that's basically all the commercial payers that you send to. That includes Medicaid, Medicare, Medicare secondary, federally funded payers, et cetera. Where it doesn't include is sort of your auto and litigation and your work comp are not considered HIPAA-covered entities. But we'll talk a little bit more about that, because a number of the work comp providers, payers, not providers, but networks and payers are actually have adopted the new codes as well. So here's kind of the breakdown, right? This is, similar stuff you've seen in some of my previous presentations and slides. So how they break down the various levels of complexity, low, moderate, and high, the core components, right? Personal factors and comorbidities, body parts, structures, functions, activities of participation or restrictions, et cetera. That's part of that sort of the examination section. And then you get into, stability of the patient, right? How stable is the patient? Are the conditions and presentation of the patient stable? Is it changing and evolving, or is it completely unstable and maybe even unpredictable, right? So, and then your decision making, is it relatively low complexity, so straightforward, et cetera, or is it more moderate complexity because of a number of the other elements and components, or is it unpredictable because it is so evolving, unstable, and there's unstable in so many different things. And the other big thing that continues to come up, and we'll talk about it in the FAQ section, is the approximate face-to-face time, right? So lots of questions about, should I record time? Is that a hard requirement? So the answer is no, you don't need to record time. It's not a time-based code. It's an untimed code. And the other thing that sometimes we throw into that scenario is, okay, so when they say approximate, that means at least 20 minutes in order to do a low complexity, or at least 30 minutes to do a moderate complexity. And that's not true either. We all know that you could potentially have a 15-minute eval and it would be low complexity, and there's nothing wrong with that. So try not to get too hung up on that. We'll talk about that more in the FAQs and some of the decision process you can go through, making sure you're selecting the right one. I guess good and bad. The good thing is no matter which one you select, the RVU is the same. So you're basically going to get paid the same right now for the eval codes. There's a little bit of an uptick on the re-eval codes on that RVU, specifically referencing the work RVU component. Is about 1.2 is the same for all codes, and that's true for the OT codes as well. It's the same. Nice little link. APTA continues to do some good little education on this as well. So that quick guide, that's a hot link there. It's also available on the resources. Good information, and they're really keeping on top of this because there's lots of feedback that's going on as we go through this. Always keep in mind when it comes to the eval, like, even though we have all these components and sections to justify the level of complexity you choose, the bottom line is, from when it comes to an eval perspective, you need to be basically patient medical history, you need to be doing your examination, clinical presentation of the patient, and clinical decision-making, right? So as you go through your components in creating your plan of care, those are all parts of the eval, and this is just kind of breaking it down. And we'll talk a little bit more specifically about the body part structures, activity limitations section where we have these things called elements and what are elements later on. And also give me some sense of like what stability is, right? When you talk, give me examples. So I've done that later on in the presentation we'll talk about. So when you talk about the different component definitions, right, so we went through this before, so what are personal factors, right? So, male or female patient may come into play, the age, coping styles, the background, education, et cetera. Activity limitations, difficulties an individual may have executing a specific task, action, or activity. And then that whole body regions, body systems, body structures. You're going to see me talk about this a little bit later, but you need to be, I would really highly recommend you spend some time on the ICF sites, and I've given you some links, because a lot of this, if not all of the source of this, is coming from the International Classification of Function. Very similar to where we saw the functional limitation reporting. So that source of where these things are defined, the overall body regions, the body systems, structures, participation in activity, those are all, and I reference those as well, those are all coming from the ICF. So it's really, really good to get familiar, with that as you go through these. So here's a little chart, sort of the model for the ICF. When we look at health, condition, disease, or disorder, and then as you see, you see a lot of parallels to what we see in the eval codes: body structure and functions, impairments related to those things, functional limitations as it pertains to activity and activity restrictions, and the ability to participate. Are there disabling things that need to be referenced? Again, those are all part of sort of that middle component or of your examination. And then the personal factors and environmental factors, right, which lends to your comorbidities or impact. And obviously all those things as it pertains to the plan of care or the treatment you're providing. Nice little link down below. It's on this slide. It's also on the resource slide to the browser. It takes you right where you can see and open up the various chapters. And I reference those a little bit later on so you get a sense of some of the elements components as well. But really starting to familiarize this, we're going to see more and more of the ICF involved in our clinical documentation and justification for payment as the payment model continues to evolve. So from the OT side, same thing, codes were effective Jan 1, we deleted 97003, we deleted 97004, the re-eval. They have 3 levels of complexity as well. The re-eval as well was replaced, and a little bit of an uptick on VRVU as well. I want you to note specifically on both the PT re-eval and the OT re-eval, there are some pretty defined requirements that you need to pay attention to, right? So there has to be an active plan of care already established, right? You need to, if you're going to charge for a reevaluation, you need to, actually that code's wrong there, so we need to fix that. That should be 97168 on the reeval for OT. But there's specific things you need to do this. This is not just kind of doing a reassessment or sort of a progress report. That doesn't justify being able to charge for a reeval. So pay attention to those components. I'll be putting some stuff out on that specifically because I think we're going to start to see potential issues with that as we move forward. So here's sort of the breakdown from the components, again, for the OT perspective. One of the things to pay a lot of attention to, that there's some sort of debate or sort of warning or alerts on, is the performance deficits, definition of component. So the way the AMA specifically describes those I would say the American Association the Association of Occupational Therapists, right, they have taken, for lack of a better term, an exception to that definition. And they're kind of redefining performance deficits a little bit of a different way. So as an occupational therapist, when it comes to trying to understand the better way to determine performance deficits and what they really are in order to select the most appropriate code, then I would be really leaning on them. They got a lot of good stuff out there. Even if you're not a member, there's a letter they updated within the last week or so on performance deficits, and this link takes you to that and some other references I give in OT. So that's on the performance deficits. The other sort of strange thing is the comorbidities component, where we have none, will affect, or may affect. Sort of how vague is that, may affect? What do you mean by may affect, right? So that's kind of an interesting thing. It's certainly, the OT is not, the components are not necessarily, to me, as clear or succinct as the PT one. So I'm feeling for my OT friends, particularly if you're a hand therapist and say you've got a PT hand therapist and OT hand therapist working side by side, when they're choosing the appropriate level of complexity, that can be, because so there is some variability and difference, that can be a little bit frustrating. So the big thing, like, we get into the examination components and the body structures for PT, body components, activities, activity limitations and participation restrictions, etc. So that's the big section where we're really lean on a lot. The performance deficits is sort of that corollary or parallel in the OT world, and it is quite well defined by the AMA as to what this is. And again, that letter down below that link, the performance deficits and the new evaluation CPT codes from the AOTA, that's where you'll see their language differing from what the AMA says, and so how they're interpreting, and they're really trying to emphasize their profession, and they want to make sure this isn't going to impact them down the road. So this is one thing they're really kind of taking exception with, and I would really read through that from an occupational therapy perspective and get a good sense of that as you move forward. So here's some things to think about with the new codes. So we know, similarities to the old codes. So whether it's a 97001 or 97003 PT and OT, right, it's still an untimed code. Just because they have the guidance on time, it's still an untimed code. You are not required to document the amount of time you did in the eval, etc. And there's no, like, it has to be at least that amount, as I referenced before, right? It's an approximate, it's a guide, and that's all it's meant to be for the time being. It is considered like the other codes, right? Bundled to include assessment, communications, review, your documentation time, etc. You can bill for treatment that same day and the eval. We'll talk more about that. I think it's in one of the FAQ or one of the questions that we've seen come in. You cannot bill for additional tests and measures for the same day. And that doesn't mean tests and measures, but some of the manual muscle testing assessments, CPT codes, some of the range of motion assessment codes, right? Those are, there's some edits on those. That's not the same as just doing manual muscle testing or doing range of motion. And I'll reference those more specifically later on. And that's the same way it was before, nothing new, right? All the HIPAA covered entities must use the new code. So that's kind of the rule of law, and that includes, Medicare, Medicaid, all the big ones, et cetera. And the Groundhog Day references, while they were all supposed to, many of them struggled to implement it January 1st, which is kind of shocking when you think of all the things we have to implement very quickly with regulation changes. It was 3 codes, right? It wasn't like ICD-10. It was 3 codes, right, on the eval side. And the re-eval was even easier. It was simply swapping out 1 code. So the fact that they weren't ready is shocking, and yet it's not shocking. So let's talk about some updates and changes that we're aware of, that we've seen since Jan 1. So I know we saw reports of denials and errors with Aetna with delayed implementation of the new codes. My understanding is that has been resolved. We also saw Blue Cross Blue Shield in a number of different, in California and in Tennessee, had some issues. California, I don't know if it's been corrected yet, but they had delayed issues. Tennessee had issues up until like the first week or 10 days into January, but I believe that's been corrected for Blue Cross Blue Shield of Tennessee. The other one we heard about through a couple of our big clearinghouse partners was Gateway Health Plan. It's a managed care organization for Medicaid, and you would think that at least Medicare and all Medicaids would have been fully compliant, and you can see maybe why some of the commercial payers were not. But they've kind of said, look, we know these ended, et cetera, but we're still opening, we're still accepting the old codes, and we have an implementation date of August 12th for the new codes, and or basically what they're saying is they may even take the old codes up to August, which to me is just hysterical that they would be able to get away with that. So anyway, keep on that. You need to. This just tells you need to be watching your payers and your denials, and we'll talk a little bit more about that in the FAQs as well, because there have been some edits and errors with the payers. So you really need to be managing. If you're doing it really well and picking the right new codes, but they're getting denied, that's something that needs an awful lot of attention and education to make sure it's not impacting your cash flow. The non-HIPAA covered entities, obviously the workers' comps, the auto, legal, et cetera, didn't have to comply, but I know that Align Network sent out to all their providers as a work comp network that they were going to be accepting the new codes. I heard that MedRisk was also doing that. They're another big network provider, and several actually of the work comps were doing that as well. Some other updates and changes. We know that some of the clearinghouses, certainly our biggest partner, Zermed, one of the best clearinghouses in the country, stays on top of things. They have 2016 evaluation code edits in place for a lot of the payers, so they're kind of trying to catch it before it gets to the payer and you get a denial, and making you aware of that. And they've been a great source of what they've seen the payer community doing or not doing with successful implementation of the new codes. From a CMS perspective, so the new correct coding initiative edits, the new edits, version 23, came out near the end of the year for that first quarter, Jan 1 to the end of March. And there was definitively some errors in it, specifically in the hospital, the outpatient hospital version, as it relates to that the provider, the PTP, or the provider-to-provider code edits, which really, if you have multidisciplines in your facility, you need to be paying attention to. So the code pairs where there's an edit, basically what it did, you know how we have sort of that 0 and 1, and the 0 on the CCI edits basically says you can't modify these, they are mutually exclusive, and then the 1 says, well, you can, but you need to modify it so we know they were separate and distinct services provided. So these three pairs, 97162 with 97165, currently has a 0 on the outpatient hospital version, right? So it's saying you can't. It's going to deny it if you bill both these. Same thing on the 97163, 165. Medicare and CMS is aware of the edits. There's a technical letter that they've written to all of the MACs regarding the edits. They're supposed to be putting a workaround in place, and the plan is on April 1st, all of those edits will be corrected with the new release of the edits for the second quarter. So keep on top of those, particularly if you're in a multidisciplinary provider setting where you've got PTs and OTs specifically with these code combinations that you could be getting denials, on the claims. So really, really track that and be following up. APTA's got some good information on that as well. I believe the AOTA does, they're tracking it as well, but that's something to stay on top of because it's going to impact you. We'll get corrected and make sure that the MACs, et cetera, are following up with correct workarounds during this fourth quarter. That's the only ones we've heard about right now that is an issue. So I just gave you a little bit of a snapshot. All these codes are new, and obviously this was part of the CCI edit. So, and I just gave you a snapshot of the most commonly ones used for the private practice setting. So from Jan 1 to Jan 31, and you see where you see Y or and kind of relates to a mutual exclusivity, meaning it's not modifiable, and the Y is modifiable. And I highlighted in red, not for any reason, not that that's a hard edit or it shouldn't be there. Don't misunderstand that to the other edits I just referenced. It's just showing you there the specific edits as it relates to the new codes. All of these edits are obviously new because all the codes are new, but I just highlighted specifically where you can see some of those things there. So this is available, and we've got links to the CCI edits that are available just so you can see those, you can access those, and again, clearly not a time code, as you can see. And so that was the PT ones, and here are the OT ones, same reference. So keep on top of that. So let's get into something interesting, which is sort of that, what do we see the first results and trends? So we did some data analysis of what we're seeing in the first, almost the first full month. So let's look at some data. So some results. This is what we've seen so far. So if you look on the left side, sort of in the green, is the physical therapy results, and on the right, in the purple, is the occupational therapy results. So you've got the individual codes and then the utilization, how many times they have been used in an eval for an eval, and then their percentage utilization is more around, okay, it's how many times that relates to the total number of our sample. So as we would expect, the 97001 is relatively low. So, and the way we looked at the data is, so that's going to probably be your work comps, your autos, et cetera. And so we would expect that to be low, and we would expect that to continue to trend downward. What is interesting is the low complexity and the moderate complexity, within these two, the 161 and 162, they basically make up 90% of the evals. So I don't know what I was really expecting to see, but certainly we see a significantly low number on the high complexity, which I think I would have expected to see. But again, this is more true outpatient setting, true private practice. This is not a heavy hospital. So it's going to vary by setting without question, right? So, and so what I didn't provide you is a whole lot of detail, but most of this is true private practice, outpatient, physical therapy, and occupational therapy. And so as it relates to that, as we start to look at potentially benchmarks or norms, if there could be, but there's such variability. But to get a sense, what are we picking? That's what I thought would be interesting for you guys to see. And on the OT side, very similar trend, right? So the old code, very small percentage, and probably will trend down. The new codes, most of them, lower, moderate combined, again, are almost 90%. And so that's kind of what we would expect. So to me, it was interesting to see the similarity. The only thing that's flipped is there's a higher percentage of low complexity versus a little bit of a higher percentage on the moderate complexity with OT, which is interesting. So anyway, interesting data to look at. We may continue to provide some sort of trending with this and to give you a sense and clarify specifically the source of the setting, et cetera, so you can do more appropriate comparisons. But I always think it's interesting to look at the data and see kind of how we're doing. So let's get into some tips and tricks. So when you talk about the new evaluation code selections and the examination component of your eval, so when we get into, or when we talk about that component of body structures, functions, activity limitations, or participation restrictions, what are these elements, whether it's, 1 to 2, 3 or more, et cetera. What are elements? So what I kind of tried to do, I took a scenario that we used before, sort of a clinical vignette, and said, okay, here's a 47-year-old female with a 4-year history of intermittent low back pain, increasing in frequency to daily over the past 2 months. Her BMI is 34, no other comorbidities, fluctuating pain from 3 to 9 out of 10. Now it's 8. We did an oswestry that was 37. She works as a school teacher and is interrupted at least once a week at her work due to her low back pain. She is unable to stand more than 5 minutes, and her sleep varies, but is impacted at least 3 out of 5 nights. So when you look at what are the elements, so again, really using the ICF, and there's a really good sort of checklist that ICF has, and I've given you a link to that in the resources. So, okay, body function. So quality of sleep is impacted 3 to 5 nights. So that would probably fall under the mental functions, quality of sleep, and that little code that you see here, down the B1343, that pertains to the ICF. Classification. So, so that would be an element. I would consider that one element. Fluctuating intermittent low back pain would probably fall under sensory functions and pain, and the ICF reference to that is B28018, 013. So you do not have to document these, but as you get comfortable with what, with the ICF and how it classifies as function and impairments, et cetera, this will become a lot easier to do for when you're picking elements. And so that's the body functions. And then under activity participation, obviously interrupted work and employment due to the ability to stand for more than 5 minutes. Mobility, we're all familiar with mobility. That's part of sort of the functional limitations section. And again, that little D415 is just a code that you'll see as a reference in the ICF. So getting, when they talk about what do you mean by an element, you can start to look at things as being, as you look through the lens of the ICF, it becomes a lot easier and clearer, and it should really help you with selection from a level of complexity. So the other one was, okay, clinical presentation, stable, evolving, or changing, unstable. So pulled some examples of what do you mean by that? Well, so I think we all know this inherently, but it's always nice, I think, to have examples to reference. So obviously, what would be stable or uncomplicated characteristics? Well, a patient has centralized low back pain, no weakness, no radicular symptoms or tingling, et cetera, no loss of bladder functions, et cetera. So that's pretty stable, uncomplicated. A post-op patient who has the incisions intact, there's no heat on the incision, there's no drainage present. They may have edema or pain, which we would expect post-operatively, and even if they're present or not present, they're probably predictable. So that we would expect that with that condition, so that's stable and uncomplicated. An ankle sprain may have pain and swelling, right? It's a grade 1 ankle sprain. They may have sort of a painful or antalgic gait pattern. Again, all what we would expect to see with that type of a patient, completely stable. Well, let's talk about the evolving one. And so a patient who has, okay, low back pain again, but now they're getting radicular symptoms down their leg and numbness and tingling right all the way into their foot. Well, that's more changing. That's something else going on there, right? You would see that as potentially an evolving. A patient with, say a total left knee, but now they're having some drainage, and the drainage has interesting color, and it has an odor to it. Maybe there's even what you consider to be excessive heat around the site of the incision and drainage. That would not be, that would be more, evolving or changing characteristics. And then a CVA or stroke patient. This is an example of sort of, don't always think that the evolving and changing has to be negatively evolving or changing. It can also be evolving or changing sort of an improvement perspective. The fact that it's evolving and changing makes it more, it just basically changes the perspective, right? So here's a CVA patient who is flaccid right upper extremity, but is now beginning to see some tone and some changes in that extremity. Well, that's positive, but it's still an evolving and changing characteristic, right? So don't always look at it just like the time. Don't think it's a minimum, right? If it's evolving or changing, it could be evolving or changing for the betterment of the patient, and that would still meet that component or category. And then unstable and unpredictable, right? Fluctuating irregular heartbeat, respiratory rate, or blood pressure. A patient who has, episodes of vertigo or dizziness that are unknown. We don't know what the cause. You don't know what the time frame is, or the origin, as to when it occurs, or if you don't even understand maybe what the triggers are. They can't tell you what the triggers are. Definitely unstable, unpredictable characteristics, which would add to that complexity. A patient with significant variations in their pain level, and again, no known trigger or cause, and it's not necessarily caused by what you would think like increased activity or a number of different things you've given them to do at home and where you see some increased pain. It basically starts to make no sense. It becomes unpredictable. Those would all fall into that category. So from a coding perspective, the kind of link to documentation and coding. So, make sure the level of complexity is supported by your documentation. So don't get so, make sure it's really easy. If I look at your eval or your re-eval, but if I look at your eval, it should be clear to me what level of complexity you would probably pick without looking at what you coded, right? And so, document what you do, document what the patient reports to you. Those are all really important things, and it makes it easy to do. You'll see this in the FAQ too, but avoid upcoding, right? Not that I don't think we do this, but this was a big issue with E&M coding when it first came out. But, understand that you have to meet all the criterias in order to appropriately choose that level of complexity. So, if 2 out of the 4, components are moderate, then it's still going to be low complexity, right? If you have 3 out of the 4 are moderate, it's still going to be low complexity, right? And so, assuming that the 4th one is a low complexity. So, it's not there's no tipping point of once you have, you have to have all 4. It has to meet the criteria for all 4 in order to pick that level of complexity. You can only do 1 evaluation code sort of per day, per discipline, right? So obviously a PT can do 1 and OT can do 1. And the other thing on the coding edits is there's nothing that says if that patient is being evaluated by a PT and separately by an OT later in the day that they have to choose the same level of complexity, right? I can't remember if that's in our FAQ, but I've seen that as one of the questions. So the OT can justify and appropriately pick a moderate complexity, and the PT may pick a low complexity. There's nothing wrong with that, and that should be continued to be supported. We talked about this on the payer side, but you need to be really auditing all your payers to make sure that they're accepting the new eval codes and that you're being billed, right, appropriately. For our understanding, we haven't seen that anybody's taken the approach that they're going to pay you differently because the RV is the same. From what I've seen talking to the clearinghouses, et cetera, and what we see coming back in ERAs, that it's consistent. But those are things you need to take in consideration. Audit and check that stuff. And I would do that all the way through the first quarter as we already see some of the CCI edits that are aired out, and hopefully those will be corrected and should be corrected with the April 1st CCI edits. But just because the CCI edits get published for Medicare, we know other people adopt those edits. Other payers will adopt those things. So don't, as I said, look at everybody, right? Really adjudicate everything carefully to make sure you're getting paid what you should be getting paid. Billable assessment codes and eval codes can't be used on the same day. So, when you think about those things, and you really need to be thinking about that's the same. That is not different, as I said, from 97001 or 97003. So when you talk about sort of those manual muscle testing codes and the range of motion codes, so, basically, you'll see those, manual muscle testing codes. I'm talking about 95831, 95832, 95833, 95834. You can't bill that and the eval code on the same day. Same thing with the range of motion testing assessment codes, which are 95851, 95852. You can't bill those and the eval on the same day. So that last bullet point says, look, you can charge for the following combinations on the same day. You can bill an eval and treatment. Yes. You can bill assessment and treatment. Yes, talking about some of those codes. Physical performance test, but also 97003 97750, I think it is, for the physical performance test. Again, you can bill that and treatment, but you can't bill that and an eval on the same day. So those are all part of the edits, and you should see that, but keep a track on that. But that's consistent with the previous eval codes. Nothing new introduced there. So let's get into our some of our frequently asked questions. And again, please submit stuff to us during the presentation, after the presentation. We're publishing FAQ we've got based on a number of questions from numerous sources, but I will love to continue to add questions as you see them arise, as this really is an evolving thing with these new codes being adopted. So from a documentation, I kind of broke these down into sort of documentation-related questions, some billing and coding related questions, and sort of general. So, and they're not perfectly set in each category, and I'll apologize for that, but they're relatively appropriate for each category. So is the level of complexity, is it dictated by the lowest level of the three areas, personal factors, exam, clinical presentation? And basically the answer is yes. We just talked about that, right? You have to satisfy all of the components for each level of complexity. And so, think about that, particularly when you're doing the low, whether is it a low or moderate, is it a moderate or high? And it's kind of, there's just a decision-making process you can go through. If there's no comorbidities and no personal factors that is affecting the plan of care or your treatment plan, none whatsoever, it's a low, right? So if you satisfy successfully any one of the four of the low complexity, it's already a low. You don't even have to assess the others to determine what it is. So kind of go through that. It's a good decision-making, sort of workflow to go through it and make it easier on yourself. Should clinicians document why they picked low, moderate, or high evaluation codes? I think it's always good, right? I mean, your documentation should support what you're doing, your treatment, and what you're charging the patient. So yes, I think it's good if your overall assessment and your plan, it should support it, right? You don't have to specifically go, okay, on the personal factors and comorbidities, here's this. On the body structures and functions, activities, participation, here's this. You don't have to do it by component, but generally your documentation definitively should, here's why I pick low, moderate, or high complexity. And obviously your documentation needs to meet the necessary requirements for an eval, which we all should know and be adhering to. And I think a lot of the EMRs you guys are using and ours, we have some of those required components already built in to make it easy for you to meet those guidelines. Does the typical face-to-face time refer to the evaluation or subsequent treatment times? So that either that approximate 20 minutes or that average, sort of the time thresholds given on the low, moderate, and high, does that refer to the eval or the overall session, which includes potentially treatments I perform? Well, I think we all know the answer, right? So the face-to-face time refers to the evaluation time, but it shouldn't be a deciding factor in which complexity to choose. It is a guideline, right? So you could easily spend 30 minutes and it's a low complexity, right? So that is a guideline, right? It's not something you have to document and record. It's not a time-based code. It is simply a guideline, and it's not at least this amount of time. So, but it does pertain specifically to the evaluation time. So some more documentation questions. To help justify the complexity level chosen, would a goal be required for all the elements identified in an eval? So when you talk about body structures, body functions, activity limitations, or participation restrictions, et cetera, when you talk about those, should you have an individual goal for each of them? It's not a requirement, and to be honest with you, more than likely, you're going to have multiple elements that you're addressing toward a single goal, right? It's probably overkill that you can easily, you may have one element definitively has a goal, and then two more, they're combined for another goal. So don't think you forced to do it. And the key to that question, the way I read, would a goal be required for all the elements? So no, a goal is not required to support the evaluation code selection. Obviously, multiple elements easily, or multiple functional limitations can easily be tied to a single functional outcome goal. So lots of questions about sort of tests and measures. So does the visual analog scale for pain or manual muscle testing count as standardized assessments and measures? Yes, they both count. In addition, if you're examining different areas, they can count for each area you're examined, right? So I think there's another question detailed about this, like do we have to do, do you have to do a standardized test, like whether it's a photo or a Oswestry or a DASH? Do you have to do one of those in order to qualify for the standardized assessments and measures, et cetera? And we'll talk about that when that question comes up. Can activity limitations be by patient report, or does it require a functional assessment in the clinic? No, you're going to, when you take those subjective information and data, when the patient says, look, you know, we talked about that in my little clinical vignette, you know, my work is impacted because of the following, right? I have to make these accommodations in order to get through my day, my sleep pattern, some of the things I do at home. No, you don't have to. The key is, are you documenting that in your clinical documentation? So if you know, as that old saying, if you don't document it, it didn't happen, right? Or it doesn't exist. So yes, you can. It does meet that. You're fine with the activity limitations, documenting that by patient report. If you want to do something to evaluate that or what may be triggering those restrictions, that's excellent, and that may even be another element. Here's kind of going to what I was talking about before. This is a question. Does every patient eval need to include a standardized test in quotes, right? Meaning your lower extremity functional score, a DASH, right? The back index, you know, Oswestry, et cetera, or do items like range of motion and manual muscle testing that have established norms, you know, count? So, you know, here's a little paragraph on this. So for PT evals, right, so one of the 4 components is determining is the examination and using standardized tests and measures, right, in quotes. So standardized tests and measures does not mean that you must use an outcome tool as a DASH or upper extremity or a Berg or Oswestry or neck, the NDI, right? Standardized tests and measures include taking range of motion measurements, performing manual muscle testing, taking girth measurements, assessing pain, assessing gait and balance, okay? So if you want to supplement it with a standardized outcome tool like the Berg or like, you know, the Oswestry, like the DASH, great, absolutely, right? Those are good things to do because you can see really good comparatives with those in addition, but it's not a requirement in order to meet that component. So let's talk about some billing and coding questions. So, you know, question, have the new NC, you know, the CCI NETs, you know, for 2007 being released? Is there any information on the use of the 59 modifier with the new eval codes? Yes, they have been released, and here's a link to where they are. This may have been a question that came in near the end of the year or beginning of the year. So yes, they're out there. It's version 23. There's a private practice and an outpatient therapy version. They're pretty similar. But again, keep in mind that edit error on the outpatient hospital provider to provider. There's those 3 edit code pairs that are wrong, right? It has them flagged as a 0, which is mutually exclusive, not modifiable, and that's wrong. The MACs have been made aware. There's a technical letter out, but they have been released, and they're out there for the new codes. Are we allowed to bill for an eval or treatment in the same visit? Again, this didn't change from last time, right? So you could have billed 97001 and treatment in the same visit. You can still bill 97161, 162, 163, and treatment, you know, one of those eval levels and treatment in the same visit. So yes, you can document and bill for the evaluation treatment interventions on the same visit, not a problem. Any recommendations? This is something I saw a lot of, right? So a lot of pre-auths or So what do I do now when I need to get a pre-auth for an eval? What code do I use in the outpatient setting? Because there's now 3 of them. You know, you've got a couple of different options, right? You can either submit all 3 eval codes for prior auth and hope the carrier just approves evaluation. You can choose one of them. You could just submit a pre-auth for evaluation for PT, you know, et cetera. So, you know, I keep an eye on that and be talking to the payer, particularly all those payers that require pre-auth, and you'll start to see some trends. We're going to track this and follow this ourselves. Obviously, with the billing services we provide, we're on top of this, but we're recommending, you know, submit all 3. Basically, since the payment and the RVU is the same and the payment's the same, it's not a big deal from a pre-auth perspective. They're only authorizing the same value. It's to do an eval. So what eventual complexity level gets assigned to it really should be moot to them at the point, but I saw this question come up numerous times. Some other billing and coding. How do I do an eval for a patient with workers' comp primary and secondary? So obviously it's not really how do I code an eval. So this is interesting, right? Because you really need to, where is the workers' comp, right? So are they using the new codes? If they are, then you don't really have an issue, right? You can start using the new codes. But if they're not using the new codes, then you're more than likely you're going to have to use the old codes for the workers' comp, right? And then once that claim's processed and now you're going to start to go to secondary, you're going to need to switch the reevaluation codes to from the workers' comp to the new eval codes. So keep on top of that in order to submit to Medicare. So again, one of those other complexities, it's you may have others like this, and auto and legal, where they're taking the old codes and new codes. So I would try to look at best practice, but I would really be talking to your work comp. Don't just assume they need the old codes, because as the work comps really seem to be adopting, particularly the work comps, really seem to be adopting the new codes. So I see this as becoming less and less of an issue, but where we may see auto and legal and some of the other like litigation, et cetera, so a no-fault insurance carriers, they may be the laggards in this, and we may have secondaries, commercial, one of the new codes. So it's a good thing to keep on top of. Can a reevaluation code be used to discharge? Well, this question came up in a couple of different players. I saw this question come in from for us. I saw this on APCA. And so the first thing I'm going to tell you is a reeval code, when you're billing for a reeval, that needs, the reason you do that is you have to have an existing plan of care. You need to be pulling in all the history and be reassessing using standardized measurements and tools, et cetera. And the reason you're doing it is something is changing. You need to update, change, alter the current plan of care. That's why you do a reeval. Don't mistake doing a progress report like we have to do for functional limitations. Don't mistake just reassessing the patient as it may seem like a reeval, the work may seem, but in order to bill for it, it needs to be a change. Something is going on that requires an update or change to the plan of care. And that's not a change from this year, from last year, right? That's the same way it has been. So I know there's a lot of effort in doing reassessments or progress reports to update for whether it's FLR or something, but that doesn't automatically justify and warrant billing a reeval code. And we want to keep an eye on that from an audit perspective, because overuse of that could end up becoming a problem for us. But hopefully that's clear. So I say that to say, if you're discharging the patient and it's the last visit, why would you bill somebody a reeval? The plan of care is not changing. The plan of care is to terminate seeing the patient or send them to home, right? So just because you're doing a final reassessment does not mean you should bill them a reeval. So is it okay for a PT to code a different complexity level than OT? I think I may have talked about this before, but we've seen this a couple of places, particularly when you have practice settings where PT and OT are same in the same practice setting, et cetera. When you may have PTs and OTs sitting at lunch or at break saying, did you code them a low, moderate, or high? Well, I coded them a moderate. Oh, maybe that's a problem. I coded them a low or I coded them a high. Yes, the complexity is based on how that patient presents to you and the specific components and criteria you're looking at as an occupational therapist and as a PT, right? So your clinical presentation based on the components, the elements, how the patient presents, whether comorbidities are impacting the plan of care or not, are different, right? And so as you use that, your criteria is different, so it's quite common that you would see this. I also put the note in here on the result is note that the CCI edits have errors that cause rejections that will be corrected. On that provider to provider, particularly in the outpatient hospital setting, edits, there are those 3 code pairs or 3 known edits that will be corrected. There's supposed to be a manual workaround up until then to correct them, but on April 1st, when we get the new CCIs, those should be corrected. Some more billing and coding. When do you anticipate the start of stratified payment for these tiered evaluation codes? Well, this hasn't been determined by Medicare, right? So CMS plan is to assess the implementation of these codes over the next couple of years. May take determinations about stratified payment in the future. And from what we're hearing from CMS and AMA, et cetera, we believe this to be also true for the commercial payers. So not sure about work comp, but certainly the HIPAA-covered entities, we believe that right now they're going to continue to pay you the same, even though they're tiered, so the stratified payment won't be different. I don't know what work comp's going to do. We're going to keep on top of that to see if they stratify payment, because a lot of the work comp, like Louisiana and some other states, they used to have tiered levels or stratified payment for different tiers. So whether they invoke that or not, we'll be checking on. But we may or may not see that, but they're going to take at least the full year assessing this, and I imagine maybe 2019 we might just start to see changes in payment. Will the complexity identified in the eval impact the number of visits that will be covered by insurance companies? So there isn't supposed to be, right? So this is kind of there's an urban myth out there that says if I see somebody 2 times a week for 8 weeks, that's moderate. That should be a moderate complexity. That really has nothing to do with it, right? You can have a high complexity patient that you're going to choose to see once a week for a period of time and then kind of reestablish something. So, because that's maybe all they tolerate. So there is no direct relevance or correlation to the frequency and duration of therapy visits to the level of complexity, right? So you're going to see some stuff on the AOT on this and APTA, and they're really getting ahead of this, so it's not going to be used against us, where they're trying to match the frequency and duration and correlate it to a low, moderate, or high. But our interpretation, our belief is no, it should have nothing to do with that, and there should be variability around there. Some general questions, and I know I'm getting close on time. What sort of auditing will occur in the future on these codes? The first year of these codes, again, they've decided not to revise. They're instructing auditors to hold off on audits for the first year. We expect more information to be released on how these codes will be audited in 2018. So again, there was a good question from before, but a little bit more detail on that. This is a good question about, we have lots of questions about PQRS codes. Okay, so PQRS codes, so we know that 97001, 97003 were sort of denominators in a number of the claims-based PQRS codes or triggers as to when you should report PQRS quality measures. But PQRS ended, right? It ended in 2016. MIPS started in 2017. Some of the same identical quality measures that existed in 2016 are now quality measures that are part of MIPS, but they're no longer called PQRS. I know it's semantics, but it's important semantics, right? So here are the quality measures that you can report. There's 6 of them for physical therapy via claims that are part of MIPS. There's no penalty for not reporting successfully. There's no benefit to reporting successfully, right? And so underneath there, underneath each of the measures, I put the eval codes that are sort of triggers as to, so if you do one of those, you should be reporting those measures. It's up to you. The recommendation is that if you want to continue, you're in the good habit of reporting these quality measures as we prepare to become possibly providers that are covered under MIPS in 2019 at the earliest. It's a good habit to get into, but I completely understand if it's something you don't want to burden yourselves in doing, given documentation time, et cetera, with some of the systems. But we have more information on that as well, but it kind of came with the new eval codes. Are there national norms or ratio for the low, moderate, or high? There isn't, right? There isn't. I don't know if they'll publish them just because of the complexity comparison or benchmarking. It's hard across the various settings and the patient mix. However, some of the data we showed you for our setting, we're going to continue to provide some of that utilization data and ratios for our clients to give you some sense of where you are. And those are things that just good sort of data and analytics we would like to provide for our clients. In what outpatient settings, and I think we're wrapping up questions, will the new evaluation V-eval codes apply? So if you're billing CPT codes as part of Part B in any form or fashion in rehab, you are part. So private practice, physician-owned, therapist-owned, outpatient agencies, CORFs, skilled nursing facilities if you're doing Part B, hospital outpatient departments, home health agencies providing outpatient therapy in the home under Part B. There's also some weird exceptions, right? So Medicare patients seen in the hospital and emergency department that are sort of treat and street, as they say sometimes, not admitted, probably would be Part B. Observation patients seen in the hospital and then discharged home, probably be Part B. Some of the same additional settings, it's the same question. So again, inpatient patients who have exhausted their Part A benefits and do not have any Part A benefits could be candidates under that scenario for Part B, right? So there's a few ancillary settings, but if you're using RUGs, if you're not using CPT to bill, then we're not required to use the codes. If you are using CPT for any billing purposes as part of Part B, yes, you are. I know we kind of went over, Megan, so if you have questions and answers, hopefully submit them in the Q&A window, submit them in the chat window. We will definitively get to them. I'm going to Megan, blow past this because I quickly want to get to the last two slides. So please submit them to them. We'll get them on the FAQ. We'll get answers to you, and we'll get them added to our FAQ and make available for everybody. Additional training resources, we've got some new training coming up. It's going to be available in March, which is, okay, now I've done these, how do I go back and edit or adjudicate, or if they got coded wrong and I need to change them, or how do I manage these with payers and in my physician practice or in my system or in my EMR. We've got some really good training about how to do that coming up in the next couple of weeks. And MedBridge is MedBridge is a great partner of ours from a home exercise program and patient engagement platform. They're one of several partners we have in that area, but they've got a really nice free education on the new eval codes. It's accessible, really, really good to use and access. And then finally, here are all the resources that I pull from and continue to update. And all these links are hot to be able to go pull from that stuff. And I can't recommend enough going to the ICF and incorporating some ICF education and training for the physical therapy group to get familiar with that. We are going to continue to see that become a bigger part of our payment model moving forward. And the more you're aware of that, the better. Megan, back to you.
Thank you guys so much for staying with us a few extra minutes, and I apologize that we did go over on time. Hopefully the questions that David went through that you had submitted previously or that we've received through our customer support teams and our account management teams were answered in those that he went through. If not, we definitely will follow up with you directly. We're going to put out that FAQ document that David mentioned as well, and all of your questions with answers will be included on that. And we'll send that out with an email, in an email with the materials from today, a recording of this